Chronic obstructive pulmonary disease, COPD, and bronchiectasis are two distinct but often related respiratory conditions that significantly impact breathing. COPD is characterized by persistent respiratory symptoms such as a chronic cough, shortness of breath, and sputum production, generally caused by airway inflammation and obstructions. In contrast, bronchiectasis involves the permanent enlargement of parts of the airways of the lung, leading to severe cough, copious amounts of phlegm, and recurrent respiratory infections. Treatment for both conditions typically involves the use of inhaled medications to open the airways, antibiotics for infections, and pulmonary rehabilitation to improve lung function. Smoking is a major risk factor for COPD, while bronchiectasis can often result from recurrent lung infections or other conditions affecting the airways. Here's a nuanced look at the detailed aspects of both diseases, highlighting their similarities and distinctions. Affected tissue, alveoli versus bronchi. Chronic obstructive pulmonary disease, COPD, primarily damages the alveoli, the tiny air sacs in the lungs responsible for gas exchange. It's often related to a history of smoking and can entail chronic bronchitis and emphysema. Patients typically experience difficulty breathing, especially during exertion, and a chronic productive cough. Bronchiectasis, on the other hand, specifically affects the bronchi, leading to their permanent dilation due to chronic inflammation and infection. The damaged bronchi fail to clear mucus, creating a breeding ground for bacteria. Symptoms often include a chronic cough with copious amounts of sputum, frequent infections, and sometimes hemoptysis. While COPD is usually progressive and related to lifestyle, bronchiectasis can stem from a variety of causes, including post-infection damage, genetic disorders like cystic fibrosis, or immune system dysfunction. Distinguishing between the two conditions is crucial since they have different treatments and management strategies. Speed of onset, rapid versus gradual. Chronic obstructive pulmonary disease, COPD, typically manifests with a gradual onset where symptoms worsen over time. Patients often experience a progressive decline in lung function due to chronic bronchitis and emphysema, exacerbated by long-term exposure to smoking or other irritants. In contrast, bronchiectasis may present more variably, with some patients experiencing a sudden worsening of symptoms, often in the form of acute exacerbations triggered by infections. The key difference lies in bronchiectasis's distinguishing feature, the abnormal, permanent dilation of bronchi, which can cause mucus buildup and lead to rapid onset of respiratory symptoms during flare-ups, as opposed to COPD's steady progression. Nature of cough. Productive with possible consolidation versus persistent without consolidation. Chronic obstructive pulmonary disease, COPD, and bronchiectasis are both chronic respiratory conditions that significantly impact patients, but they differ in cough characteristics, which is vital for differential diagnosis. In COPD, the cough is typically productive, commonly associated with increased mucus production and frequent exacerbations, which may lead to periods of lung consolidation due to infections or inflammation. Contrastingly, bronchiectasis manifests with a persistent cough that often produces large volumes of sputum regularly due to the structural abnormality of the bronchial walls. Unlike COPD, consolidation is not a typical feature in bronchiectasis unless there's an acute infection. Recognizing the nuances in cough character between these conditions guides clinicians toward more accurate diagnoses and tailored treatments. Fever presentation, high and persistent versus low or absent. In distinguishing between COPD, chronic obstructive pulmonary disease, and bronchiectasis, fever is a key differential indicator. COPD exacerbations typically do not present with high fevers unless there is a concomitant infection such as pneumonia. On the other hand, bronchiectasis can lead to chronic lung infections, which may cause persistent, higher-grade fevers. Patients with bronchiectasis often have a cycle of infection and inflammation, resulting in febrile episodes that can be frequent and more pronounced. Persistent fever in bronchiectasis is often a sign of an active infection requiring antibiotic therapy, whereas in COPD, low-grade or absent fever is more common, and treatment focuses on bronchodilation and anti-inflammatories. Thus, the fever's nature, high and persistent versus low or absent, serves as a vital clue in the clinical assessment and management of these respiratory diseases. Breath sounds on auscultation, crackles or rales versus wheezing or rhonchi. When distinguishing between COPD, chronic obstructive pulmonary disease, and bronchiectasis during a clinical assessment, breath sounds on auscultation provide valuable clues. In COPD, wheezing or rhonchi are commonly heard, indicative of the narrowed airways due to obstruction, inflammation, and bronchospasm. Wheezing typically has a high-pitched sound and occurs during exhalation, highlighting the airflow resistance in the smaller airways. Conversely, bronchiectasis is characterized by the presence of crackles or rales, which are caused by the sudden opening of the small airways and alveoli that are deflated due to chronic infection and mucus accumulation. These crackles can sound like hair being rubbed between fingers, signifying the presence of secretions in the airways and the irregular airway dilation associated with bronchiectasis. The distinction through these sounds is crucial and helps guide appropriate management and therapy for patients.